intervene on these issues and are built on the foundational concept of the 5 M's of geriatrics, as you can see here in the corner. Keep in mind that a GED is not a brick and mortar space that needs to be built, but rather a culture of care and a set of workflows to be run in parallel with normal ED operations. While there's no one-size-fits-all approach, common characteristics that you can see here are senior-specific workflows and screenings, an interdisciplinary team, specialized equipment and supplies, and physical plant modifications. Let's take a look at how the case of Jane illustrates how a GED can profoundly impact the care we deliver. Jane is 82 years old and she's widowed. She lives alone. One day she fell while gardening and she sustained an abrasion on her ankle. Over the next several days, her ankle became more red and swollen and painful, and she developed a fever and severe pain. So Jane went to a typical ED. She was diagnosed with cellulitis and discharged with 2 antibiotics. Unfortunately, over the following days, she became increasingly weak and had another fall. And she returned to the ED and was found to have kidney injury and a high potassium. And because it was busy in the ED that day, she was placed in the hallway on a gurney and a urinary catheter was inserted and she was admitted to the hospital. And her hospitalization was prolonged because of delirium and a UTI, and she needed to go to a nursing facility because of profound deconditioning. And now it's not clear when or if she'll ever be able to return to gardening again. So what if we could identify at triage those older adults who are at higher risk of adverse outcomes, and then we could intervene and reduce the risk of those outcomes from occurring? Maybe during her first ER visit, she went to such an ED, a GED, and supports such as a geriatric pharmacist who would have caught the medication error that occurred in the first place, or a geriatric care coordinator who could have orchestrated better care transitions. Staff and physicians were better educated and prepared for this age group, and they assessed her risk of falling as well and intervened upon that. And all of these interventions could have staved off decline, and maybe she would have been back gardening today. So what if she decided to go to a GED during her second visit instead? So during that visit, she'll still need to be admitted, but there they'll recognize sooner and treat better delirium, and they'll avoid iatrogenic complications like a catheter-associated UTI. They'll identify key psychosocial issues early that will help with discharge planning and allow for virtual family visits by leveraging video technology right in the patient's room, and optimize physical environment to be the least deliriogenic. And by doing all of these things, they'll shorten Jane's hospital stay from 7 days to 2 days and avoid deconditioning and allow her to go home instead of to a nursing facility, and she'll be able to regain her independence. So it's not just anecdotal examples. A growing body of research supports GEDs as the most effective care delivery model for older adults. The data show that GEDs improve clinical outcomes and reduce cost of care, decreased risk of admission at an index visit, decreased patients' total Medicare costs, and reduced or delayed nursing facility admissions. It's no surprise that the American College of Emergency Physicians developed a program to spread this model of care, known as GEDA. It was established in 2018 with a 3-tiered accreditation system that you can see here. The concept is spreading throughout the country, and since 2018, 10 EDs have achieved level 1 accreditation, with UCSD being the only one in California at this point who has achieved that. UCSF, Kaiser-Permanente, and Zuckerberg SF General are currently in the planning phase to design world-class level 1 GEDs for the city of San Francisco. This planning is funded with support from the Ray and Dagmar Dolby Family Fund in partnership with Hirsch Philanthropy Partners. And all 3 sites are applying for implementation funding. And although we each have our unique approach to the GED model of care, I hope I've been able to give you a very zoomed out overview of what a GED is and why we need them. So I'm going to stop here for some Q&A.
If anyone has questions, please type in the chat feature. Thank you. take a moment to see if anyone is going to deliver a question. And if not, then I will invite Jennifer Wong from Kaiser to open her microphone and share her screen.
Great. Okay, can everybody hear me and see my screen okay?
Yes.
Okay, perfect. So, hi everybody. So my name is Jennifer Wong. I'm a nurse here at Kaiser San Francisco's Emergency Department. You just met Jeremy, and I'm also joined by Marlena Tang. She's our local physician lead, and Ryan Wilbur, our regional consultant. So Jeremy briefly went over our GED model earlier in his presentation. Just to recap, once again, our GEDs are designed to recognize and intervene on 8 areas that are built on the foundational concept of the 5 M's of geriatrics. Our GED model will be orchestrated by multiple staff members, but today I will be focusing on the areas that most relate to our connections with all of you, our community organizations. So the heart of these interventions, such as linking our patients with the community, are our care coordinators and social workers. So I will be specifically talking about their roles across our continuum. We really want to focus on at-risk older adults and how we can better serve them. So with the implementation of our GED, our social workers and care coordinators will be taking on additional screening tools to further identify and address biopsychosocial matters. In the interest of time, I won't be going through every screening tool, but I would like to share with all of you what they might identify. With the social workers, we are going to be identifying geriatric abuse and neglect, depression, and caregiver strain. What I have in parentheses on the side here is what the screening tool is called. For the care coordinators, they will be assessing functional status in ADLs and also recognizing possible cognitive impairment. Many times, once any issues are identified, our patients are then referred to our continuum. So our continuum consists of regulated and non-regulated services. We're mostly familiar with the regulated ones. I'd like to give you a brief overview of our non-regulated services and highlight our challenges where we believe our local community organizations might be able to help fill in some of the gaps that our patients, caregivers, and family members encounter. So we want to start a dialogue together with our local geriatric community partners in order to meet some of the needs that we are currently missing. We have amazing resources within our transitions team, which is comprised of social workers, pharmacists, and a nurse. I'd like to specifically point out the transitions pharmacists with whom we recently completed a trial with, in addition to our ED pharmacist. Skilled nursing facilities and assisted living facilities have specific requirements for writing medication orders. In order to prevent any delay of administering medications when discharged, the transitions pharmacist will be completing real-time medication reconciliations for our ED patients being transferred to a SNF or assisted living facility. I'd also like to note that we also offer a life plan program where we have facilitators and classes offered by our continuum to assist patients and their loved ones throughout the advanced care planning process. Our transitions team is trained to provide life plan assistance. Our community care program is catered to our homebound patients, secondary to cognitive issues or physical limitations. We hope to utilize this resource as part of our GED in order to reduce, those taxing, unnecessary ED visits that can be taken care of in the comfort of their own homes. So emergency department overcrowding affects the overall quality of patient care, leading to increases in length of stay. We are fortunate to have a program called Care Without Delay implemented within our department. Our Care Without Delay director, who is also an RN with clinical oversight, her name is Alexa, she works together with our multidisciplinary team to prevent unnecessary admissions and instead assist with creating a plan for our patients with complex dispositions to ensure their needs are met at the right place. So our Care Without Delay goals include decreased length of stay in the ED waiting for placement, decreased ED admission rate to the hospital, and also decreased readmission rates from the ED. So another goal of ours is to ensure that all the services that we provide in our ED and the continuum are tied back to the patient's primary care physician for continuity of care. A new process that we'll be including in our GED are warm handoffs to our adult and family medicine clinic team for every GED patient that we serve. So when we identify any issues while the patient is in our care, we would also like to refer our GED patients to local community organizations. And this is where we need your help. Some of our medical centers in Northern California currently have a comprehensive case management system to address and guide our patients with dementia through the healthcare system. Kaiser San Francisco, we're currently working on expanding these services for the specialized population. In the meantime, we would love to ask for any referrals to a community case manager who can help serve this role until we establish this in our San Francisco hospital system. We are also looking for any assistance to meet the biopsychosocial needs of our geriatric patients. As I mentioned before, as part of our new care coordinator and social worker process, we'll be introducing new screening tools to identify and address areas of concern. With that said, we are looking for partnerships within our community organizations to assist with caregiver strain, food insecurity, loneliness, and additional education for family members with a large focus on dementia. At this time, we are also piloting a virtual volunteer system utilizing an iPad to address loneliness and isolation of our patients within the ED, which I could go into more detail later during our Q&A time if there's any interest. And that's it. Thank you, everyone. We're excited to partner with all of you. We'd love to address any questions or comments you may have for us at this time.
If you would place those questions in the chat feature so that the team can see, that would be great if you have questions right now. We'll take a moment. Somebody wants to know how they should get in touch about partnering. San Francisco Village asks.
Perfect. So we can actually put our email addresses into the chat. Dr. Marlena Tang is the participant running our chat right now. So if you want to get in contact with us, we'll throw our email addresses up there, and we can definitely have some conversations with you. So for the volunteers in the ED for seniors awaiting care, so our virtual, so we are piloting a virtual volunteer program. So of course, with with COVID, we have a lot of geriatric patients who are isolated. They're stuck in rooms behind closed doors. And with the nature of the ED, sometimes their stay here is quite long. So we decided to take a little bit of what they're doing upstairs on our COVID floor and get an iPad for our department. And so we do have volunteers on call. We just started piloting 2 days a week, but next week we're moving to 5 days a week. So he is on call, available to chat with our patients and just, try to spend some time with patients who might not have family members or someone to talk to. So like how we used to have, actual physical volunteers in the department, unfortunately, those were taken away with COVID. We found that this actually helps both ways for the patient for isolation and also helps our volunteers who are also isolated at home.
I think in the interest of time, if everybody finds this acceptable, we'll save some of these other questions for the very end during the 30-minute session. But I would like to move on. Thank you, Jennifer, and thank you, Dr. Schwartz. I would like to invite Dr. Malini Singh and Dr. Eric Isaacs to begin their presentation on behalf of their hospital. So Dr. Singh, I believe you're up first, sharing your slides.
All right, good morning, everybody. Thank you, Jeremy and Jennifer, for setting up that wonderful, very community-based partnership and outreach, which is why all of you are here today listening to the three of us talk about our respective emergency department programs for geriatrics in the city of San Francisco. So I would like to start off with the Zuckerberg site. Alongside me is my partner in crime, Eric Isaacs, who is actually the very proud Geriatric Emergency Department Medical Director, and I am the GED champion. Also, I carry a role of the Vice Chief at Zuckerberg. So this is very exciting for all of us. So let's start off a little bit about the why. Jeremy hit this perfectly. So I'm not going to belabor the point, but I'm just going to say one more time to emphasize, and make it a point. We are getting older. We are living longer. And the amount of people who are going to be 65 and over is going to double to 98 million from where we are today by 2060. That is not that far away. And we all lost a year to COVID, so we know how fast a year can go. So we have a lot to look forward to, but a lot that we have to deal with as well around cost. We all know elder care is more expensive. We know they use the emergency department more. We know their social resources and ED resources are higher than other age categories. The elder population is turning more and more to the emergency departments for their care. And we know this is driving up costs. Some estimates say that 1 in 2 of older Americans are actually visiting the ED. 1 in 2. And with 10% of hospital admissions that are perhaps avoidable, if we go at the pace we're going now, we are projected to see a percent of our GDP at 20%. So our healthcare costs will be 20% of our GDP. Currently, GDP is 22 trillion. So we're projected to reach close to 4 or higher. This is a problem. We need to address this now. And I'm so glad that we're all getting together to talk about how we can address a lot of the root causes, which Jeremy and Jennifer already talked about. And so already we know that our college, the American College of Emergency Physicians, has started an accreditation program in which we know from Kevin, there are about 200 level 1 GED sites or accredited sites all over the US because we recognize that this is important. And a lot of this is because of the work on the heels of our GEDC, which Kevin's work, Dr. Bice's work around the geriatric emergency care and its importance and impact on outcomes. This is the work by people like Kevin and Eula and Chris Carpenter that really, really has helped us move the needle and how we have to identify more specific care for this very vulnerable population. So what do we know about our geriatric patients? Jeremy hit upon this. They use emergency services at a higher rate. They have longer ED length of stays. Some data say up to 20% longer. They require more imaging resources, almost a half more than usual, and they use up to 400% more of our social resources, 4 times more than our regular general population. They're also more likely, after all that, to experience adverse health outcomes after discharge. And geriatric conditions in general are not adequately addressed in most emergency departments, especially when it comes around to functional dependence and psychosocial concerns. We could be a lot better on all of those issues. And after all that, of course, there are still high rates of patient dissatisfaction. So what can we do? We talked a little bit about this already, but we have more specific things we can do, like screening tools. How do we identify right at the outset that you have a vulnerable high-risk patient? Things like the ISAR, identification of seniors at risk, and the delirium triage screen are tools that can help identify early who your high-risk patients are and put them appropriately in the part of the ED with a strike team that can address their patient-specific complaints. We also can talk about geriatric-specific protocols. We know that geriatrics are not like all other patients. They don't compartmentalize their infections very well, and moreover, they have an increased sensitivity to a lot of analgesics, which our general population have a much higher tolerance for. This is why they are special in so many ways. They also present atypically. They present with dizziness and weakness, which can be masking UTIs or even worse, acute coronary syndromes. They don't present typically, they're very vulnerable, and we have to manage them different than other populations. Why? Which is why specific geriatric protocols and really a multidisciplinary approach to how we take care of them is really what we need to do to take care of them and have better outcomes. So emergency departments are challenged, as we all know, all of my colleagues on this call from all of the respective sites, we are becoming more and more challenged with the social determinants of health among all of our populations. And this is made worse among our elder population by basically their baseline poor functional dependence, recent ED hospitalization, recent ED visits or hospitalizations. If they're living alone, they have no social supports, they have comorbidities, they have a polypharmacy sitting at home. And on top of all that, they're depressed because they're often alone. All of these can add to worse outcomes because they're all social determinants that now we as the ED, because we are the only ones that can address this in real time, need to and have to address. So these are all high risk factors which can portend for worse outcomes. So what is happening now? And what are our outcomes? Jeremy already hit upon some of the really great outcomes we've seen. In general, there has been a decrease in hospital admissions and particularly in the ICUs. A lot of the long-term studies though, looking at like what are going to be the long-term effects and quality outcomes for GED still remains to be seen because we're kind of new at all this and they need to be sort of randomized control studies. So we have a lot more to go, a lot of great data coming in that we're on the right track. But we do have some things to look forward to. Okay, so why Zuckerberg? Why is GED at Zuckerberg important to do? We are the only level 1 trauma hospital in all of San Francisco and northern San Mateo. We have a catchment area of 1.5 million residents. Our census is 80,000 patients a year and growing. That was, by the way, prior to COVID, but we expect that volume to continue to rise after we're all safe and vaccinated. And moreover, we really reflect the community of San Francisco. We have a very diverse mix of patients from all kinds of ethnic backgrounds, which mirrors what is actually living in San Francisco. So our hospital reflects what makes up San Francisco. And this also is the case for the number of patients who are over 65. 13% of patients who are over 65 live in San Francisco. Our emergency department volume reflects that. We very much reflect that. However, among our trauma patients, well, 22% of the patients who come in with traumas are over 65, over 85% of them get admitted to our hospital. And 70% of these patients reach a high level of trauma mechanism, such as falls, that they need to come to a trauma center. So we need to take care of our geriatric patients in a different way than other institutions because we are the trauma hospital and falls are the most common mechanism among this population and worse outcomes come after falls and traumas. So this is a very important area of clinical expertise that Zuckerberg has that we need to frankly be better at delivering for this population. What about mental health? We have the only psych emergency in all of the city. And our geriatric population over the age of 65 make up to close to 6% of the patients who visit our psych emergency. This is among a population in the city where there's only 14% of patients who are 65 and over, and 6% of them make up our PES population. We know that older patients who make up just 12% of the whole US population account for 18% of our suicide deaths. In fact, 1 in 4 older adults experience some mental disorder along the lines of depression, anxiety, and of course, dementia, which is expected to double by 2030. This is why we are all here talking about this today. Adults over 65 also have higher rates of saying that they rarely or never receive the social and emotional supports that they need to succeed on the outside. So now that you've had a chance to hear about why we need a GED at Zuckerberg and why it's important for us to talk about this today, all of us together as a community, I'm going to let Eric tell you a little bit about how we plan on doing this.
Great, thank you, Moni, and thank you to the Institute on Aging for holding this forum, and thank you, Jennifer, for including us. The first thing I wanted to do was sort of introduce you to our emergency department. You've heard that we're the trauma center. You've heard that we are the psychiatric emergency center, and we were on a call this week with a leader in geriatric emergency medicine who had been a resident here, had done her training 30 plus years ago, and talked sort of about the war zone conditions and the war zone mentality that she experienced when she was here. And for those of you who are in the city, who are our community partners, but have not yet had a chance to visit the emergency department at Zuckerberg San Francisco General now, I wanted to give you a quick picture about what you might expect. This is not from Sunset Magazine, but this is actually one of our patient areas. So we now have a beautiful facility with a number of rooms of natural light, windows to the outside. We do not have patients in the hallways anymore. It's quiet. It's really a completely different place than what San Francisco General was known for in times past. Jeremy and Melanie have talked a lot about the current state of our older adults in the emergency departments, that they are treated really just like any other patient without any special thought or accommodation to what's different in the geriatric population. Molly, if you could go to the next slide, that'd be great. So in trying to move this project forward, we share some common goals. We are all really trying to optimize our emergency department care. We're trying to avoid hospitalization in these patients when possible. When they will be discharged, we want them to be safe discharges, and we are really trying to focus on our connection to the community. And in particular, as Jeremy mentioned, and Kevin Bice also mentioned in their chat, we are trying to really focus on our patients with cognitive dysfunction, dementia, and avoiding delirium. Next slide, please, Melanie. So this is a very busy slide, but it gives you a hint about the types of things we're thinking about going from our current state to the future state, or what really is the near future state, the near future state. That things are going to start happening, much as Jeremy referenced, from the beginning in triage, where screening is starting to happen, to when they're bedded, and we bring our geriatric gift basket, which is going to provide better care and better experience for our older adult patients, to the training the nurses are getting, the special pathways, both for clinical care as well as technological advances, allowing some alerts, to early involvement in our social medicine service, which I will talk about a little bit, to a much more robust discharge process, including more understandable instructions, better packet, communication with primary care providers and community partners, and then having a post-discharge process where patients will be called back to see what was their experience like, answering questions that didn't get answered before, making sure they picked up their medications, making sure we made the connections with the community that needs to be done. Go ahead, Melanie, to the next slide. So we have a advisory panel that's helping us, including our trauma specialists and our psychiatry specialists, as well as our geriatricians, neurologists, trying to do alternative pain management involving occupational therapy and physical therapy in the emergency department more. We have emergency department pharmacists who are going to be involved, and then our social medicine services and our data analysts, as well as our nursing trainers. Melania, next slide, please. This is just a picture of our kind of tracking and dashboard, much as every one of our emergency departments has, as well as an app to assist with some service recovery and patient care and experience evaluation. All right, so I wanted to now get to some innovative ideas. which we have a couple things I want to talk about. One is our social medicine team. And this is really about leveraging the existing resources that we have at San Francisco General. That, as Malini mentioned, and many of you know, we are the safety net hospital for the city and the northern part of the county. And as the trauma center, we are seeing everybody from the 86-year-old hiker in the Presidio who has a fall and needs to come to the trauma center, to the executives who are hit by cars, to the other penetrating trauma that may happen in the city, to our elders who may be homeless, God forbid, or in low-income housing. We are seeing everybody on the same day in the same place and need to be able to address their needs, their special needs. We have a social medicine team, which is an interdisciplinary team that is stationed in the emergency department. They round with us several times during the day. And it was really started not to address our geriatric population, but to address our other patients with complex needs, particularly social needs related to food insecurity, unstable housing, the psychosocial issues, addiction, all sort of mirroring the goals that I mentioned earlier about trying to reduce hospitalization and rehospitalization. I'm trying to link them to the community resources, for example, addiction resources or housing resources, to try and improve their care in the emergency room and then their care afterwards, all while trying to maintain the strong community relationships that improves their ability to find solutions for these patients. So right now they're working on patients in the emergency department, not necessarily geriatric patients, but we are going to, next slide please, Melanie, supplement and enrich their ability to help us identify our vulnerable geriatric patients in particular with complex needs, who share the same issues: food, housing, now psychosocial issues. Do they need in-home support? We have one social worker who tries to work on this, but is really seeing everybody in the emergency department. And so we'll benefit from a team approach to dealing with these issues. We'll also be able to, as part of our program, connecting with our geriatric emergency department nurse or nurse practitioner, advanced practice provider, to do follow-up within the next 1 to 3 days, to make sure, again, they made their appointments. Did they pick up their medications? Checking in with their caregivers about how things are going. Did they get the care, the help they need? If so, great. Did you make your connections with the community? If not, let's supplement our connection to the community to make sure that people are able to thrive in their homes or wherever they happen to be living the way that they want to live. Next slide, please. The next thing is that, like I think was mentioned earlier, we are also creating a patient and family advisory council. This is not necessarily an innovative idea in hospitals or community sites, except that in the emergency department, at least at Zuckerberg San Francisco General Emergency Department, this is new. And we will be at first incorporating our geriatric focus into an existing patient and a family advisory council that's being created for the larger emergency department. And this is going to involve our consultants, the nurses, the techs, the physicians, our social resources, as well as patients and their families who are connected to San Francisco General, who can help advise us on the current conditions, on future innovations, on things that need to be improved, and kind of solicit ideas from them how to make our care better, our experience better for them. All right, I'm going to hand this off to Melanie for the kind of wrap up.
So I want to end with a very interesting question that I think is on all of our minds, is that when we thought of an implementation of a GED over a year ago, it was a different brick and mortar kind of a feel. And what COVID has taught us is that we have a huge digital ecosystem that has come into play. And what COVID has ushered in is this acceptance, and sort of acceptance broadly by both providers and all of our patients about how could they get care at home. And this has spurred a lot of ideas that we all know about, like Cardia, which helps with sending EKGs to your providers, wearables, we know all about them. We have apps like Elevate, which help our elderly population keep their mind sharp. We also have what I find really interesting is this thing called Pillboxy, which is an app which reminds you when to take your medications, which is especially useful for our patients who might have some cognitive decline, and also to increase compliance. And of course, like models like Heal, which really foster a teledoc, in-home visits, televisits for patients like our seniors and our elders. So how does a world look like where we have these patients in the emergency department, and then we release them and discharge into this very fast changing digital landscape that many of them might be unprepared for, but that we need to be better at preparing them for, so they can be more successful in this new landscape. So I do ask all of us to think a little bit about how we, the emergency departments who are all on this call, and Institute of Aging, can really improve the education and access for our most vulnerable population to really access where a lot of healthcare is going these days, as we all know very well. So I just want to say special thank you to everybody, especially the staff and providers at the Institute of Aging, for having us here and inviting us and listening to a little bit about who we are and what we're doing to take care of our most vulnerable elders. Thank you. Any questions?
You know, we do have a few questions. I will pose one of them and maybe keep the rest for a little bit later. I believe Dr. Schwartzberg answered about the age minimums for each of the 3 GEDs. There was a question about, could a 55-year-old with advanced or accelerated aging be appropriate for GED, or would it depend?
I think that's a great question. I would say yes.
Yeah, I think if I can add on to that, you know, one of the benefits of great increasing our awareness of cognitive dysfunction for our geriatric patients is the providers and nurses, the team will have tools to deal with agitation and cognitive dysfunction in that population, which they can then transfer to other unfortunate younger adults who may suffer from the same problems. And our goal is to decrease sedating medications, decrease restraints. And so hopefully we'll be able to apply that to our 55-year-old, for example, with this cognitive dysfunction.
Yeah, I would echo what Eric said. If we have the resources, we would definitely plan deploying them to people who need the resources. The age cutoff is just where you see the higher incidence or prevalence of the disease process, but that doesn't mean there's going to be people who are not going to develop them prematurely, and we would offer those same resources and linkages and supports to the younger population as the ones who are predominantly affected in the older population.
Okay, I think this is actually a pretty good segue into the UCSF presentation, because as Dr. Degesys just informed me, it is a little bit different at UCSF, and she's going to share that during her presentation now. Thank you, Nida.
Yeah, absolutely. Thank you all so much. I know it's kind of been a whirlwind, like last 45 minutes or so. So if you need to get up and stretch, feel free to do so. Thank you so much, Kaiser and IOA, for putting this together. I think this is just yet another demonstration of how all 3 SF sites are going to be collaborating together to really share best practices and to really get the word out and disseminate what all of us are doing to just take better care of our geriatric patients in the city. My name is Nida, like Nida Sweater, Degesys like Pegasus. I am the Assistant Medical Director of the Adult Parnassus Emergency Department at UCSF, and I am the Medical Director of our Geriatric Emergency Department. But our entire team is, a lot of them are here on the call, so they might be checking the text box for chats and things like that. So please feel free to ask questions, and many of our team members will be able to answer them. At UCSF, the Parnassus campus, we are a smaller emergency department than the general, but we have a very high percentage and high volume of geriatric patients, 29% of our visits are actually age 65 plus. So that's fiscal year 19. And every year that's been increasing since we've been collecting data. And so we continue to think that that trend will continue. About half of all of our admissions from Parnassus to the hospital are geriatric patients. And we think based on national data, about 10% of those are probably avoidable. And one of the things that our geriatric emergency department wants to focus in is on how to avoid those unnecessary admissions and how do we improve that transition back to home and the robust referral process to additional or more specialized care. So our team is a really large interdisciplinary team. This concept of our geriatric emergency department, while yes, is in the emergency department, would not have at all been possible without the strong efforts and collaboration, and we would say partnerships with the department or the Division of Geriatrics, the Department of Neurology, our pharmacists, and our social workers and case managers, and our nursing staff. And so I think a member of almost every single one of those people are on our team, are on the call right now. So if you have social work specific questions or geriatric specific questions, please put them in the chat box and our geriatricians and our neurologists and social workers will be able to answer them. So that's who developed our geriatric emergency department, but that's not who you'll necessarily see in our GED during the day or during that patient encounter. So our daily GED team consists of all of the ED providers, the ED nurses, but then we have these really specialized folks. So we have somebody called the JEDI with a G, so no one's going to be sued, which stands for the Geriatric Emergency Department Implementor, and our JEDI Master. And our JEDI Master is also on the call. And what those people do, that is an advanced practice provider, so a PA or a nurse practitioner who is trained in geriatrics through our Division of Geriatrics, that will be completing comprehensive geriatric assessments for these geriatric ED patients. And they'll be working with social work, pharmacy, PT, and OT to develop a safe disposition, whether that's to be discharged or to be admitted to the hospital. We are going to have a dedicated geriatric emergency department pharmacist who will be working with outside pharmacies, PCP offices, to get a better sense of what are patients actually taking so that they can complete a full medication reconciliation, which we know polypharmacy is a huge problem. We have a dedicated geriatric ED social worker and case manager who will be providing resources and developing safe discharge plans for our patients. And we really want to use this opportunity today also is for our social workers and case managers to build even stronger relationships with our community partners that are all on the call today. We have our physical therapists and occupational therapists, and then we also have a subgroup of ED nurses who are super users. So in our geriatric emergency department, a lot of the policies and protocols that are going to be put in place are actually carried out by the bedside nurse. Our bedside nurse actually does the delirium and cognitive impairment screenings that are required for any patient in the GED. But additionally, we've trained several of our nurses to be super utilizers and super users to help train on the spot in the emergency department, the other nurses, both on using the different validated screening tools and assessments, but also to really spearhead the idea of a geriatric emergency department to keep that momentum. We have 28 protocols written for our GED. One of the main ones, which I think there were a lot of questions about, and I'm going to spend just a little bit of time on how you actually get into our geriatric emergency department. So when a patient arrives to triage, yes, for the most part, there is an age of, if you're over the age of 65, you are automatically in our geriatric emergency department, as long as you have an ESI level, which is the acuity level of 2, 3, 4, or 5. But we also recognize that cognitive impairment is not just for people older than the age of 65. Additionally, homeless patients who have been living on the street also age much more rapidly than we might tend to think for needing to be over the 65. So in our emergency department, it's any age with any history of any type of cognitive impairment or dementia is automatically placed into our geriatric emergency department, who will then be able to benefit from all of the resources that a GED patient gets. Once a patient is in our geriatric emergency department, that bedside nurse, as I mentioned, is doing a lot of the delirium and cognitive impairment screenings. If they screen positive on any of those, then they get this very in-depth comprehensive assessment by a specialized practitioner, that advanced practice provider, the JEDI. And then they will do a lot of other protocols that I'll talk about and different screenings. But let's say you have a healthy 65-year-old who doesn't screen positive. That doesn't mean that they won't benefit from other changes in our emergency department, such as easier access to food and drink, a better physical space, making sure that we still implement delirium reduction protocols, even if that patient is an overall healthy person who doesn't necessarily warrant a more in-depth comprehensive assessment at this time. They will still benefit from many of the policies and procedures that we have in our GED. A lot of the screenings, many of our institutions will have very similar screenings, just using different tools. So we will be looking for delirium, cognitive impairment. Nutrition is a really big key. Access to nutrition and food insecurity is something that's very important. Abuse screenings, mobility assessments, fall assessments. We also are focusing quite a bit on depression, especially now in COVID, the loneliness concern, the depression, caregiver burden, and the caregiver experience is a top priority for our geriatric emergency department as well. And of course, like I mentioned, we'll be doing the full medication reconciliation. We have many protocols to reduce opiate use, pain control, palliative care protocols. We have a geriatric psychiatry protocol, restraints. And then we have a very robust referral to specialty care, including things like the memory and aging clinic and some of the other UCSF geriatric clinics. I think from our perspective, it will be really helpful in this conversation after we're all done presenting is how our community partners and community organizations can help us refer our patients to a lot of things that exist for them, like daycare centers, like Meals on Wheels, and other things that IOA and Alzheimer's Association can offer. We also have a lot on residential care, discharge to residential care, and then as well post-discharge follow-up telehealth visits, especially now that many of our healthcare visits can be virtual. We are implementing a telehealth follow-up visit with the GEDI and social worker dyad to make sure that patients are actually getting the going to the referrals that they were referred for and getting the resources that we had provided for them. The thing I want to actually spend a little bit more time on with my last few minutes is really the patient and caregiver experience. We have, of course, changed physical space to make it a little bit more inviting, making it less delirium invoking, changing how the waiting room is, and making sure that patients who have a history of dementia or cognitive impairment or at risk for delirium spend less time in the waiting room and are seen more expeditiously. We also are engaging volunteers, both virtually via virtual volunteer iPads, similar to what Kaiser has, but those are limited hours. So we're also exploring how do we get maybe families to be on an iPad and they can do like a family Zoom hour with their loved one at the bedside as well. We have developed with San Francisco General Hospital a really amazing and I think very innovative concept of an elder life specialist. Basically, we have really seen that the spiritual care needs of both patients and caregivers have not been really well addressed in the emergency department. It is a terrifying place to be, regardless of your age, regardless of your past medical history. But it's even more terrifying when you're confused, when you're sick, and when you're delirious. And so how can we best facilitate getting those needs met? And so this elder life specialist is really based on what children's hospitals have done with a child life specialist coming in through the spiritual care and chaplaincy program at UCSF and Zuckerberg. And so we really look forward to seeing how that will improve the patient and caregiver experience. We've developed we're developing a what to expect when you're in the emergency guide and handout that clinics can provide their geriatric patients. We also have a patient and family advisory council. And we are in the process right now of looking at ways that we can actually quantify or qualify what an experience is in the emergency department by using a medical anthropologist and an ethnographer who actually has dementia ethnography experience in Japan in some of the dementia care homes. And so we'll be really looking forward to seeing how we can take patients' words and caregivers' words and stories and how we can bring those to light so that we can improve their experience, but we can also then share with the rest of the country how GEDs change the lives of patients and their caregivers. And so this is something that I think maybe the IOA and other community partners on the call might be able to help us with, which is how do we get our patients and caregivers more engaged with us in our GED? So we have a lot of questions for all of you out there, one of which is how do we get those patients more engaged? How do we get caregivers engaged? How do we make sure it's equitable? How do we make sure that we have representation from different groups of people in San Francisco, and it's not the same like 5 individuals who always volunteer for things, but how do we outreach into communities that are less represented? How do we get our patients now into some of the daycare programs in Iowa? We've had some trouble with that in the past. How has COVID impacted how we actually get resources to patients? How are the criteria changing? And we were hoping that at some point that maybe we could have a resource fair. And I know Kaiser was talking about this earlier as well, is that wouldn't it be great to have something like a resource fair where all the SF sites and partners would be able to share resources so that we knew what was available for our patients, so that we could get better referrals, we could help our patients more once they're at home, once they've transitioned. And if you want to partner with us, my email is down there, but this is a very big team. I would probably just send you to different people. That's it from UCSF.
Thank you, Dr. Degesys. If anybody has any questions, I think at this time we're at the half-hour mark, and this is when we were going to open it up to the whole group. And I think this might be a good time, but before we do that, does anyone have a specific question for Dr. Degesys? And type that in the chat, please.
There's a question in the chat about language and my guess is more like interpretive services. So we used to have in-person, but with COVID, the in-person interpreters have been greatly decreased just for safety purposes, but we have a video iPad available for every single patient encounter 24/7 for every language, even my home language of Lithuanian, which is like no one ever speaks, available at bedside. Our screening tools, for the most part, the delirium screening tools that we use are available in 5 or 6 of the most commonly used languages for our nurses to be able to also implement. Thank you for that question. In terms of screening, if they have a primary care physician, so I'll let the general, I know the question was for UC and the general, I can only speak to what UC is. So we do worry that there's a lot of patients who don't have PCPs. And so one of the things that our team will be working on is working very closely with the PCP, whether that's a UCSF PCP or an external PCP. If they don't have one, we will help them get one. If they do have one, we want to work very hard with their PCP to either get them more robust, like more neurocognitive referrals for dementia if indicated. But additionally, we'll be providing our PCPs who don't have access or don't feel as comfortable taking care of patients with cognitive impairment toolkits for PCPs. There's a few out there that have already been put together by the Geriatric Society of America, the GSA one that was just re-released, I guess, a month ago, which is a really good PCP toolkit, in addition to our own top 5 most common questions for geriatricians and dementia specialists.
I think the rest of the questions now will open up to Dr. Schwartzberg and all of the other presenters, Dr. Singh. So those of you who are representing the hospitals, if you would like to unmute yourselves at this time, I will pose some questions to the group. We see right here a question from Esther K. She's asking, how does insurance coverage play into the care options offered? Most of my community is Medi-Medi. Would anyone like to take that question?
I think that was, Esther, I think you meant that for me because I made a comment about Marlena made a great point about it takes a village. Both Nida, Marlena, and Jeremy and I, we all illustrate, yes, it takes a village and then some. And then the question was that a lot of the barriers we have among our patient population at times is that they might be underinsured or uninsured. And so the community resources available to them are a little bit more limited. Not all of them are on Medi-Medi. We do have a very engaged eligibility team that will get them registered, but we have a fair number of our elder population that are homeless and don't have any coverage, which does limit our resources and community links. This is why our social medicine team has been so instrumental for us, is really helping to fill that gap for our patients.
We also have a question regarding community resources. A social worker says, I'm not sure that the issue is lack of knowledge versus lack of availability. For example, currently the wait lists for community case management for low income patients is months long. How can we work with the county and state to improve this? Anyone want to take that?
Since Jeremy, I think Jeremy's trying to talk. Jeremy, you trying to talk?
You're on mute.
Can you unmute yourself, Jeremy?
This is Marlena. Can you hear me?
Yes.
Okay, sorry.
Yes,
I can
Marlena,
just
we can.
I can just speak. I would say that we really need help with that too. I think in the ED, we have a mandate to see everybody and treat everybody. So regardless of your ability to pay, you are going to be getting GED services from all three of us. It's really for us, we need help with the follow-up post-ED visit. We in the ED, at least I can speak for myself, most of the community resources out there, I didn't know you guys really existed until I started working with older adults and really looking into what's out there. And so we really want to improve the care post-ED visit. We're going to be treating everybody the same while they're in the ED, but to really make a difference in the ED, we need access to what you have and your knowledge. And that's why we are hoping you can educate us a little bit. I totally agree with Terry, like the waits are really long. That's a question that I probably can't answer as an ED provider, but we can all agree that it's something we definitely need to work on, and maybe we can partner with you on improving that too.
Dr. Schwartzberg, I see that you're back. Are you unmuted now? I think something might be going on with your computer. I see another question here that says, I can't remember whose bio included experience in verbal de-escalation skills with people with cognitive dementia issues and or psych issues in ED and or crisis, but can someone speak a little bit about that?
I think that's probably referring to my partner in crime, Dr. Jim Hardy, who is working clinically until 3 today, so couldn't be on this call. But there is a lot of training that goes on in our department and at the general for verbal de-escalation. And as well, we have all of our sites, I'm sure, will be implementing some sort of agitation order set that, you know, decreases the amount of restraints that are used, tries to first address a lot of very like common complaints, like a full bladder, because actually that causes a lot of distress and discomfort and some behavioral manifestations that we might not like in the emergency department. So trying to use less restraints, trying to use less pharmacological ways of sedating patients, because that can also be risky. So there's a lot for that in all of our institutions.
There's a question specifically here for Dr. Singh. Medical interpreters are thus important allies as US gets more diverse. How easy is it to get a medical interpreter at GEDs? Also, is there a standard glossary of terms across the US that medical interpreters could use to standardize complex terms?
That's a great question. So we have access to 35 or more different dialects. We are currently using mostly phone interpreters. and I'll have Eric chime in as well. I can get the most obscure language, and we'll usually find somebody that speaks it who's available for us. They are all trained medical interpreters, so they are all trained to be able to interpret the terms, even complex health terms, into the language that we need. So I have had very little issues getting interpreter the dialect I need. Some might be more difficult to get at 2, 3 o'clock in the morning. And also, moreover, with their geriatric population, what I feel like I'm more challenged with is hearing loss. And because we have been more limited now to phone interpretation because of COVID, there is a population of geriatric patients I would very much like somebody to come down in person to help interpret, especially our trauma patients and so forth. However, we've been very limited with that. So that has been a little bit more the gap I feel like I'm feeling the pain of, is I'm not able to really serve our older patients that are a little hard of hearing. But we almost invariably will have staff that are also trained as medical interpreters to be there in person. And our common ones are usually Cantonese and Spanish. So we generally will have a lot of staff in Tagalog available in the ED to help us with that. So I would say we're very privileged that we have access to interpreters. I would love more in person. And I'll let Eric chime in about any thoughts he has about that, but I've had very little issue with interpreters at the general.
I think you said that beautifully. I'm not sure I have much to add except to just reinforce what you said, which is we use a professional interpreter services who are well-versed in medical terminology and are comfortable asking us for clarification or asking us to use different language when it's necessary.
There is someone who's asked about Terry's comment about lack of availability of community resources. You see it in the chat there. It's due to wait lists and poor funding. Is the ED-MD Association partnering with other professional organizations and political leaders to push resources? You have a lot of valuable data and experience to advocate for more access to more older adults. Would anyone like to take that?
I think the answer would be yes.
I wanted to say to Dr. Schwartzberg, since he seems to not be able to speak over the mic, Dr. Schwartzberg, if you want to type answers into the chat feature, please do.
I'm not sure if I fixed my problem.
Oh, you did. Beautiful. We hear you loud and clear.
Okay, sorry about that.
We should let you speak first now. Sure.
Oh, well, I love the question. I wish I had something valuable to say in response. I'm not familiar with advocacy work being done with the government and other organizations to increase funding for this. But I mean, I think the question just is right on. But yeah, I don't have much to add about that. Sorry.
I wonder if Kevin or Eula, who can speak more from like the national collaboratives perspective and maybe ACEP's perspective, they might have some idea if that's happening on the national level, if they're still on.
Hi, I apologize. I joined late because I had some other competing meetings, but could you, I guess, frame up the question for me in a broader sense again?
I think the question was more globally about advocacy at the national level for a lot of like the lack of availability for community resources for geriatric patients or GED stuff in general.
Yeah, so I think that's always the biggest challenge. And I think on a national level, I think awareness is probably the biggest and the earliest direction. And the awareness of the fact that there's a vulnerable population within the emergency department, and then the opportunities then on a local level because I think all business is local. And so on a national level, you can sort of have like broader mandates and awareness of larger programs being aware. But then if those programs aren't available on a local level, it's going to be different. And the populations are also different by the resources and the patient needs, and the population needs are variable. But I think as an example, I think what we're trying to do from the GEDC, so the Geriatric ED Collaborative, is integrate the awareness of opportunities in many of the presentations that were given today I think the last thing that I saw in the chat was about social work. So not all hospitals may have access to social work or case managers, and then how those social workers and case managers may function, and then their ability to then connect with various community resources, that's also going to be variable. But the thinking and the integration of their roles with the transitions for a lot of these patients, whether they're specifically dementia patients or patients who may be homeless or whatever various community resources there are, it's all about those connections and the awareness. And so I hope that helped to answer the questions a little bit.
Thank you. Because some people entered the presentation a little later, I'm wondering if I could pose this question. If a caregiver takes their loved one to the ED, would they have to ask for them to be seen by the GED, or is this a connection that is automatic? And I'm actually going to pose it to Dr. Schwartzberg because he didn't get to answer many questions because of his technical difficulties. Dr. Schwartzberg.
Thanks, Calvin. So, you know, most of the GEDs will have their own screening criteria. So when a patient comes into triage, they will have their own criteria set up to identify patients who are most likely to benefit from the GED interventions. So actually, you know, all GEDs will have a little bit slightly different criteria. But no, family member or a loved one does not need to request to be added into that population. It will all be part of the process and the workflows of the GED.
This question is for anyone. Can you please say more about the technology related to addressing loneliness? Dr. Singh, I see you nodding your head affirmatively. Might you speak to that?
Yeah, well, I think that was what I was referring to at my last bit of my talk, is that it's the digital world is just overwhelming. There are many apps out there. There are also like distress apps for people who are feeling lonely and having thoughts of hurting themselves as well. What I find very challenging is in navigating, number one, how do we get our elder population more familiar with devices and using them and basically, frankly, having access to them? Number two is having devices that are really sort of amenable to the elder population in terms of font and easy to use. And I know that I think something called Granny Pad is out there that helps with that, but I don't have a lot of familiarity with that. And then number three, there are so many apps out there for so many things. The digital startup world is extremely competitive because they know now is the time. They have a huge user base that are interested in digital apps. There has a lot of investor money in this right now. The thing is, how do you navigate which ones are most effective? And I think that's very user dependent on their access, their devices, how tech savvy are they? So I would say I love that the space is becoming full with need-based apps. I worry a little bit of navigating what's going to be most useful for our population. And I think there's going to be a lot of studies about digital apps and their effectiveness and outcomes in our very near future, especially in emergency medicine. I look forward to learning more about that. But we as acute care providers and IOA and others, we'll probably have to learn how to link patients to these resources and devices and teaching, frankly, about how to use them. So they're out there, but it's no use if they're not being used.
Yeah, I would agree that there is pickup with this technology, even in this age group. And it seems daunting, but I think there's a lot of opportunity. Currently, we're working on a pilot to look at volunteers who can interact with patients in the ED. So through basically like a FaceTime type app. And these volunteers, Marlena on the line and Jen actually have piloted this already in the San Francisco KPED, where they found that the volunteer themselves actually has quite a lot to gain from interacting with patients over virtual visiting. And it actually has made a big impact on one particular volunteer's life to be able to play a role, especially now in COVID, where normally they would want to be able to partake in community volunteerism, but are not able to. So it has brought up this virtual technology solution that I think is promising.
One more thing, Jeremy, thank you for all that. That's absolutely spot on. The other notable inequity we've all realized during COVID is just having access to Wi-Fi. And so, you know, we don't know where a lot of our patients who are come to us, are they in areas, can they afford Wi-Fi? Can they afford the broadband access to be able to use these apps in the intended way that they were used? So that's another issue that I know that we've all learned with COVID as well, among all populations.
Someone is asking about the adult day health centers. Not sure what the California State Legislature decided, but funding for those centers was recently on the chopping block. Does anyone here know the status of those programs? Can any of you talk about how you might work with the adult day health centers? Dr. Isaacs, it looks like you want to answer that question. Am I wrong? You did.
I was smiling because I don't know the answer to that question, and it feels like something I should know the answer to. I think I need to be educated more, although my default answer is, well, I probably should learn more before I make my default answer, but it's you know, part of the community connections that I think we're interested in bolstering and facilitating our relationship, or strengthen our relationship.
Maybe we could flip the question to the group, only because I know one of the things that we're trying to do is refer to these adult daycare programs. And so that has been challenging for our social workers in the near past. And so is this something that our partners can help us with, getting these referrals more expedited and making sure that the inclusion criteria for these ADHCs is either like better publicized, or that we're more aware of it, because we're trying to figure out how to best refer to those services.
So I'm happy to talk about that a little bit. Again, it goes back to I think this is a good example of the awareness around community programs, and again, engagement on a local level of your case managers or social workers, the outreach to, in this case, the example of adult daycare programs, right? So this is the inflow and the outflow of patients that are coming through the ED. And I'm looking at the chat a little bit about, you know, patients that kind of come in and out of the ED. You're going to think that it's a medical issue, but sometimes it's, more often than not, it's also a psychosocial issue, and it's the social supports. And so is there, you know, connecting them to something like an adult daycare? Maybe there was a problem with the adult daycare and the patient there. And so having all of the transition and interdisciplinary staff that are part of the ED know that there's a program now that's focused on these older patients, and how can they better connect? And then also in the same way for these adult daycare programs or the elder programs that might exist in your community, to be aware that your ED is now moving forward with these types of initiatives. So that mutual connection and awareness that these things are happening, you'll start to see the organic process of, I think, the patients now having better referrals or the opportunity to connect. I've seen this happen in several of our emergency departments over time, where they have begun to integrate these programs, and social work is able to, the patient that you had, you know, we've now connected, and they've got an appointment where we're going to connect them to an adult daycare program for better support for the caregivers. Maybe the caregivers weren't aware. So it's a lot of it's promoting awareness, and then and it's sort of leveraging and aligning resources that are already out there that maybe in many cases you weren't aware of each other and were siloed. So.
We have a question. How are the GED pioneers dealing with and addressing people's right to refuse and comply, if they're not conserved, of course? We are so familiar with seniors who revolve door, the ER, etc., regardless of APS engagement. Who would like to speak to that?
Yeah, I love that question because I think we are all familiar with that scenario of patients coming in almost passively suicidal, completely not, you know, almost not taking care of themselves and self-neglect because of mental health issues. And I think it is one of the main pillars of the GED is actually making sure that the care we provide is in alignment with the patient's goals. So whether or not that's been established, hopefully prior to the ED visit, is the number one priority, is to have outreach from outpatient partners through life care planning type services to ensure that goals of care are thought out early on and are well communicated in our electronic health record, so that we all have access to that. And then making also having processes in the ED through physician education to not only clue into these when they're in the ED, but also to better assess for patient capacity and decision making, and to make that a little bit of an easier process for physicians, because that is extremely challenging in the ED.
I'm going to follow up on what Jeremy said, which I think is really, really important. I don't know how much earlier was discussed around sort of the age-friendly framework of the 4 M's and, mobility, mentation, medications, and in this case, what matters. I would say none of the GED programs are meant to, be foisted on any patients. And key to it is it's a patient-centered approach. I think geriatrics in many ways is a patient-centered approach. So it's all of the clinicians and the team, the interdisciplinary team that surround the patient, and whether it's in the outpatient setting, the inpatient setting, or in this case, the ED setting, it's putting forth like why the patient's there and what trying to serve their needs. And I think for us in the emergency department, we're very used to just like focusing on the medical diagnosis, but now it's trying to think a little bit more holistically about all of the other aspects of health for that individual and that patient. And so, to Jeremy's point, the goals of care, why are they there, and what can we do to help them? That's the purpose and the goal. So.
And just also adding on, what we found with our other high frequency utilizers in the emergency department with complex social needs is that by engaging with them, by developing relationships with them, where initially they may have been quite resistant to any service, with time and stronger relationships, they're more willing to accept some support. And I think that's one of the other benefits of the geriatric emergency department approach.
I also want to just chime in to what Jeremy and Eric said. We have shown by proof of concept the benefit of interventions like bringing care to the patient. Like another vulnerable population is our substance abusing group. And so part of our social medicine team does involve a MAT team, or medical assisted treatment team, that goes to the patient, talks to them about options in the community to transition to things like buprenorphine or methadone to get them off substances. We also have alcohol treatment programs that we can enroll patients in as well. So to Eric's point, if we bring those resources to the patient in the real time of the crisis when they're there with us, that is the most opportune time to get education for the patient and engagement. And we found that those have been successful, and that's everywhere in the ED literature about how early intervention with medical assisted programs like buprenorphine and so forth have shown good outcomes. And similar to pediatric emergency department, stroke care, STEMI care, trauma level designated hospitals, they've all shown that when you have clear protocols addressing the clinical process at hand, you are going to have better outcomes. We are very early in the GED process, and we've shown some early data that show that. But I just want to emphasize, while none of our GEDs are up, I know that Nida chimed in that her protocols are already working. Jeremy and Kaiser are already working on it as well. We've always taken care of these patients. We just want to know how to take care of them, identify sooner, and deliver better care to them. And that's more effective and impactful and engaging for the patient. So that is what we look forward to implementing at the General, is that we've been taking care of these patients our whole career. But how do we do it that's really targeted and focused like we've done for other vulnerable populations, like I mentioned earlier? And that's our journey, and that's what we all look forward to actually getting together too.
I think we have time for one last question, and I see it posed there right in the chat feature. Will any of the volunteer programs be administered or staffed by the GEDs? Will volunteers receive specialized training, support, monitoring, intervention on ESP or ESP if working with PWD? Anyone can answer that. Dr. Degesys.
So our volunteers that will be working with our GED patients, once COVID is lifted and we are allowed to have volunteers back in person, will receive similar training to what our ACE unit volunteers have. So they will be trained to work with a geriatric and cognitively impaired population. That's just at UCSF. I don't speak for anyone else.
Dr. Swartzberg, would you like to answer that one from your perspective?
So we, at this point, our volunteer program has been more virtual because of COVID. And I spoke to that a little bit earlier regarding our virtual visiting that we have piloted and we plan to go through with. But once we can bring more people physically into the hospital, then we're going to have to work on more of a robust in-person volunteer program.
And finally, Drs. Singh and Drs. Isaacs, would you like to address that from your perspective?
I think we're each waiting for each other. Our volunteer program has also been suspended due to COVID. And I think we are considering how we could use volunteers in such a capacity. Our volunteer program prior to COVID was focused a bit more on our trauma and acute care patients. The volunteers were, I would say, on the younger end of the spectrum, and probably would need to do a lot of infrastructure building to develop that for us. So I would say we are still thinking about it at this point.
I just want to add, we are very lucky to have a very engaged residency program and medical school. And so Eric and I have been very grateful that we've had very engaged medical students and residents who want to help implement a GED at Zuckerberg for all the reasons everybody mentioned today. So while we're lacking that volunteer program at this time, we have a huge interest among our learners to want to be involved in any way they can. And that's been a great resource for both of us.
I'm going to announce that it's the 2 o'clock hour, so we are at an end, but I want to thank you all so much on behalf of IOA and the greater aging services community. Thank you to all of the hospital representatives. We will be staying in touch with all of you. For those who are on the line who are expecting continuing education units, I, Catlin Morgan, I'm the education manager for IOA, will be attending to those within the next few days. I'll be reaching out to you. But again, thank you so much. IOA was honored to present this today. We have made a recording. We'll see how it captured, and we'll be sending that out to all participants. And we will also provide you with contact information for all of the people who spoke today, because it's obvious that many of us are eager to engage with this project. Thank you.